This presentation is on antibacterial and anti-infective agents. This corresponds with Chapter 9 of the antibiotics in the Karsh textbooks, but there are no specific page numbers referred to throughout this presentation, so it could be transferred to use with other pharmacology books as necessary. Part of this presentation is material that is used in a Creative Commons site as well, and I've added to that information and personalized that using the Karsh textbook. So when we look at these susceptible organisms that we are trying to use anti-infectives with, we see lots of organisms that we want to target with some type of medication. So specifically in this presentation, we're going to talk about bacteria, but we will also in other presentations talk about viruses, perhaps retroviruses, fungi. Those are all ones that are associated with the module of infection in the first semester curriculum. But we may also in the future be talking about organisms such as parasites, protozoas, helminths or worms, and we will talk about and have in the anti-infective presentation bacteriostatic versus bactericidal. Bacteriostatic, which will reduce the ability of that susceptible organism to reproduce. Bactericidal, which will kill the organisms. Some medications that we talk about will only be cause that susceptible organism to be either killed or inhibit its ability to reproduce if we have the right amount of medication. So often we'll do lab tests called peaks and troughs with certain medications that have to stay in a certain therapeutic range. That they have a very narrow range in which those antibiotics or those anti-infectives can work properly. So a peak would be completed at the peak of action of that anti-infective, and a trough usually right before a person is going to get their next dose of a medication. So when that medication is at its lowest point of amount in the body. So when we look at bacteria and how it's classified, it can be classified by being gram-positive. So the cell wall retains a stain or it resists decolorization with alcohol. Gram-negative loses the stain or is decolorized by alcohol. So we'll describe organisms as being gram-positive or gram-negative. And then we'll look at antimicrobials or anti-infectives that are effective against both of these types of organisms or maybe against one specific type of these organisms. We'll also talk about bacteria that is aerobic or it depends on oxygen for its ability to survive versus anaerobic bacteria that do not use oxygen. So those are things that we need to know about the bacteria itself so that the correct anti-infective or antibiotic is used. So when we look at antibiotics, we're going to define antibiotics as chemicals that inhibit specific bacteria made in three ways. So antibiotics are either going to come from living microorganisms through synthetic manufacturing or through genetic engineering. So when we look at the goal of antibiotic therapy, it's pretty it's pretty common. It doesn't matter which antibiotic we're talking about, the goal is pretty much the same. We want to decrease the population of the invading bacteria to a point where the human immune system can effectively deal with that invader. So we want to only use antibiotics to the point that really we're as a supplement to the human immune system where at all possible, so that we're going to decrease it enough until the immune system can actually take over and deal with it effectively. So how do antibiotics work? So we looked at this more in general in the general anti-infective presentation, but we'll revisit it here again. So antibiotics can inhibit cell wall synthesis of that microorganism, can alter permeability, can inhibit protein synthesis. It could inhibit even RNA or DNA being synthesized within the cell or interfere with metabolism. So every antibiotic does not work in exactly the same way, but you see them work pretty much using one or more of these particular mechanisms of action. We also talk about the word selective toxicity. Um, so when we're talking about selective toxicity, we're talking about the ability to injure a target cell or a target organism without injuring other cells or organisms that are in intimate contact with that target. So there are some antibiotics that have selective toxicity. They're going to target a particular type of cell or a particular organism without injuring what is immediately surrounding them. Also, when we're talking about anti-infectives, we want to also talk about the words pharmacokinetics and pharmacodynamics. So, pharmacokinetics is the study of movement of drugs within the body, versus pharmacokinetics is how a drug affects the organism. So you can see here, here's our little organisms. So pharmacodynamics is how that drug is going to affect these organisms. Pharmacokinetics is how that medication is going to move to the body. And here we have kind of a graph showing how we're getting that drug till it's in a steady state actually in the body. We need to have an understanding of how the particular antimicrobial actually is working, but what it's going to do to the organism, but how it's also going to move through the body to the target areas as well. So there is a CDC campaign to prevent antimicrobial resistance because that is a major problem. And we did talk a little bit about antimicrobial resistance in the general anti-infective presentation. But here's some recommendations. We should be using aseptic technique for all procedures. So if something requires medical or surgical asepsis, um, we should be using that. We should be using gloves with all procedures. We should be, using sterile gloves when sterile gloves need to be used, clean gloves when clean gloves are supposed to be used with all the things that we are doing. Um, we should obtain culture specimens appropriately so that we do it in the right way. We're not contaminating the specimen, and that those are being obtained, sent to the lab in a timely fashion in the correct way. Also, that there's timely communication of what those culture and the sensitivity results actually are. It does take some time, usually like 48 to 72 hours for a culture to grow. Um, but that once we do have results back from that CNS activity, culture and sensitivity, that's communicated in a very timely fashion. Also, that we're adhering to isolation procedures. This is one that I see that we don't do as well with. Maybe we're getting better, I hope. But often, I see nurses who either they just won't go into the room because there's isolation procedures in place, like you're going to have to gown and glove to go into the room. Maybe it's a contact isolation, or it's, droplet or airborne type of isolation that dictates the kind of PPE that we wear, but that we're not following those policies and those procedures correctly. And then clear documentation of improvement or worsening of symptoms of infection. So that we need to have good documentation. We need to be able to communicate what is actually going on with the patient. Did the antimicrobial, is it helping? Is the infection getting worse and the antimicrobial isn't doing anything? So that needs to be communicated clearly. And one that we should know by heart, that we're cleansing hands between each patient. And I think we're a little better at this, maybe in the acute care setting, but we still have a ways to go. I was talking with a manager who was posting up her percentage results of complying with hand hygiene practices, basically following this practice that I'm gelling in, I'm gelling out, or I'm, doing soap and water hand hygiene before and after contact with patients. And I think the percentage on the unit that I was at the time was at 87%. And she said, that a lot of studies say if you can get a unit to at least 85%, that it's almost like 100%, because you're doing it a majority of the time. That number should be, I think, higher than that, because I think it should be close to 100%, because we should be doing that every single time that we enter a patient's room, we exit a patient's room, we're changing gloves, we're changing procedures that we're doing. We should be cleansing our hands very, very often. In the anti-infective general presentation, we did talk about resistance to antibacterials or anti-infectives, and it is a problem. Um, and there are some bacteria that are already sensitive, that are already have some resistance. So we have sensitivity versus resistance. We've got drugs or bacteria rather, that are going to be sensitive to the use of a certain antibacterial. Then you're going to have bacteria that are resistant to certain antibacterials. You have some antibiotics that are inherently or naturally already have a resistance to certain antibiotics. But then you have those that have been acquired as well, through really, inappropriate use and issues that we see related to acquired drug resistance. So with drug resistance, you know, we essentially we have facilitated by our usage of antibiotics, particularly um, the development of resistance, because and we talked about this with the um, previous presentation, the general anti-infective presentation, but that we're very concerned about the fact that we do have antimicrobials out there that have become resistant. The microbe becomes resistant to the drug, and so then the drug cannot perform its mechanism of action effectively. And so, three of the major concerns that we have is MRSA, VRE, and MDR-TB, which is multiple drug resistant TB, and we mentioned these in the previous presentation as well. But with MRSA, which is methicillin resistant Staphylococcus aureus, it's widely resistant to almost all of the penicillins as a class, and so there is a very drastically reduced ability of any of those penicillins to inhibit cell wall synthesis. There's also other strains of MRSA that are resistant to other antibiotics, such as the aminoglycosides and the tetracyclines. Of course, VRE is resistant to vancomycin, but it's also resistant to the penicillins. It's resistant to aminoglycosides like gentamicin, and you know, other antibiotics have been used in their place like Cipro, and it's very possible that those are going to become drug resistant as well. TB is we do have a strain of TB that is multiple drug resistant, and so because of this, we really don't have the adequate therapy to be able to treat that very well. And often the cause of being resistant to multiple drugs is that the duration of therapy was much too short, the dose was too low, or patients were not compliant with their therapy. They started feeling a little better, or they just quit taking their medication altogether. Another part of infections and the use of anti-infectives is the fact that some of our patients have nosocomial infections, that they did not have an infection when they came into the hospital, but they have been given an infection while they are there with as part of their treatment. So look, we inserted a Foley catheter, we gave them a UTI. We didn't wash our hands, we passed an infection from another patient to from patient to patient. So that's something that we need to really be aware of as we're providing treatment, is the prevention of nosocomial infections. Another part of thinking about infections and anti-infectives, antibiotics, antibacterial medications is we want the right drug for the right bug. And so when we take a look at that, we want to do culture and sensitivities. We want to do microscopic examination of the microorganism. But sometimes, we feel like we do not have the time for that. So we have to look at empiric versus rational therapies. Okay, so when we look at empiric therapy versus rational therapy, empiric therapy is more like therapy based on experience. It's an educated guess. So if I'm a practitioner who is working in a community clinic, and I've seen 20 25 cases of strep this week, and my next patient has similar symptoms, based on the community I'm dealing with, I'm probably just going to go ahead and prescribe a medication that will be effective against strep, because I'm thinking, well, that's the most likely thing that this person probably has. It's based on the experience, and I'm using an educated guess to pick the medication to use, versus rational therapy, which says I'm going to pick the right drug for the right bug. I'm going to prescribe the right drug in an adequate dose for the sufficient duration and the appropriate clinical needs. So that might mean I'm going to culture and do a culture and sensitivity. I'm going to pick a drug that is going to affect that microorganism that is specifically involved, which is going to take more time. And so sometimes we feel like we don't have the time and we start off with an empiric therapy. We go ahead and collect our specimens for our culture before we start antibiotics. And we go ahead and grow the culture, and then we might end up changing the medication somewhere along the route of therapy. In the previous presentation in anti-infective, we did talk about identifying organisms. So that could be by shape. It could be by looking at them under the microscope. So you can kind of see in these pictures, that you have some that are different colors. So that refers to like the gram staining. And growing them in culture would also help us identify those organisms. Once they have grown, then the lab tests them for susceptibility or sensitivity to certain drugs. So then when we get those results back, then it would tell us what the pathogen is and what medications would be best to be prescribed for that particular uh, bacteria. There are some other factors that we will need to consider when we're looking at antibacterials that are going to be prescribed for patients. The drug spectrum needs to be considered. Are we talking about a broad spectrum versus a narrow spectrum? Is it going to kill a wide variety of microorganisms or only just a few? What kind of drug dose? So the dose is going to need to be appropriate for the age, for the weight of the patient, and that it's appropriate for the clinical needs of the patient. The duration of the medication, it needs to be the right amount of time for the clinical needs of the patient, as well as the site of infection needs to be considered for the right med to be chosen. So we might be needing to think about the site. Does it have poor vascularity, poor absorption? Are there foreign materials in that wound or that are a part of that site of infection? And that would need to be considered when the medication is being chosen. So we're going to look at some specific types of antibacterials coming up next. So we're going to start with a look at antibacterials with the classification of aminoglycosides. So with aminoglycosides, these are a group of very powerful antibiotics used to treat serious infections that are caused by gram-negative aerobic bacilli. So some of the common medications that we use: amikacin, gentamicin, kanamycin, neomycin, streptomycin, and tobramycin. Neomycin is usually topical, but most of these are IM or IV. Typically, with your aminoglycosides, we're doing peak and trough levels. Peak should be determined 30 to 60 minutes after drug administration, and troughs are collected before the next dose. Peak levels typically above 10 to 12 micrograms per milliliter, and troughs above 2 micrograms per milliliter are associated with nephrotoxicity. Gentamicin and tobramycin, the therapeutic level we're looking for is 5 to 8 micrograms per milliliter. With amikacin, we're looking for 20 to 30 micrograms per milliliter. The issue with aminoglycosides is that there is a potential for serious adverse effects, such as nephrotoxicity and ototoxicity. Typically, they are not given orally because they are poorly absorbed. When we give aminoglycosides in a low dose, they are considered to be bacteriostatic. Higher doses, they are bactericidal. And we do, as we said, peaks and troughs for these, and often these are going to be administered in empiric therapy when we know that the organism is an aerobic gram-negative organism. The prototype for this classification is gentamicin. With aminoglycosides, they are bactericidal if they're given in high enough doses. We are talking about serious infections, particularly aerobic gram-negative bacteria, and they inhibit protein synthesis in susceptible strains, causing cell death if they are given in appropriate. As far as the pharmacokinetics of aminoglycosides, they are poorly absorbed from the GI tract. So again, that's why we typically do not give these orally. But they're more rapidly absorbed after an IM injection and reach peak levels within an hour. They're widely distributed throughout the body, but they also do have the potential of crossing both the placenta and entering into breast milk. They're excreted unchanged in the urine and have an average half-life of 2 to 3 hours. It does depend on the kidney for excretion, so it does come out through the urine, and aminoglycosides are toxic to the kidney. Contraindications would include known allergies, renal kidney disease, or hepatic disease, and current and hearing loss. And significantly is that those adverse effects, ototoxicity and nephrotoxicity, are the most significant. That's the black box warning on all aminoglycosides. And so knowing that, we would need to be alert for any signs and symptoms that would kind of give us the clue that there are toxic effects that are going on, like dizziness, vertigo, tinnitus, hearing loss, changes in output, in terms of the kidneys, that would give some indication to that. There are drug to drug interactions. So aminoglycosides will have some negative interactions with things like diuretics, neuromuscular blockers, succinylcholine, or citrate anticoagulated blood. Also, kind of to mention here is that aminoglycosides are often given in two dosing schedules. So, kind of in a conventional way where, they might be given, say, every 12 hours. And that would be more conventional dosing. And in some cases, they're given in a different type of dosing, which is like a once daily administration. So the more conventional type of dosing, where they're getting it every 12 hours, we do your typical traditional peaks and troughs with that. With once daily dosing, we wouldn't necessarily do peaks and trough, but we might would do random 12-hour serum evaluations. If we're doing, whether we're doing peaks and troughs or we're doing random evaluation of the level of aminoglycosides in the serum, dosages would be based on the serum drug levels and the creatinine clearance of the patient, telling about how their kidneys are functioning. Also to mention here, there are some medications that can mask toxic effects, that would mask the effects of issues of either ototoxicity or nephrotoxicity. So while someone is on an aminoglycoside, we should be monitoring their renal function. So looking at their BUN, their urine output, their creatinine clearance. We need to monitor their drug levels. So looking at either their peak or trough levels, if that's what we're looking at, or if we're doing random serum evaluations, that we're looking at what those levels actually are, and that we're watching for signs of toxicity. Okay, so nursing considerations for patients receiving aminoglycosides. We would want to assess for possible contraindications and cautions. So, in particular, allergies to any aminoglycoside would be significant. We would perform a physical assessment. We want to know a baseline for our patient so we can compare their baseline to any changes that they might possibly have. We would want to be aware of symptoms related to ototoxicity, nephrotoxicity. Do they already have hearing loss? Um, Signs and symptoms of any type of peripheral neuropathy that we might want to be aware of. We would perform culture and sensitivity tests at the site of infection, to make sure that aminoglycosides are the most appropriate for the pathogen that's involved. We would conduct orientation and reflex assessment, making sure that, we're aware of, how our patient is functioning as a baseline to compare them to later. And assessment of vital signs, of course, and performing liver and renal function tests, particularly since we know that aminoglycosides can impair renal function. We would be monitoring renal function, like looking at creatinine clearance, BUN testing, urine output, as well as serum drug levels and looking for signs of toxicity. So with aminoglycosides, your prototype is gentamicin. And so we do know that to be used for serious infections that are caused by gram-negative bacteria, given IM or IV with a half-life of 2 to 3 hours, and knowing that some of the serious adverse effects do include, in particular, nephrotoxicity, um, and can cause dizziness, rashes, and fever as well. But we would be more concerned about those toxic possible effects of ototoxicity and nephrotoxicity. So here's a question. So tell whether the following statement is true or false. Because of the adverse effects of aminoglycosides, it's important to teach uh, the client to restrict fluids and eat 6 small meals daily. So no, that would be false. The rationale would be to provide the following patient teaching, which would be to drink a lot of fluids and to maintain nutrition, which would be very important, even though nausea, vomiting, and diarrhea may occur. And then the fluids are going to be important because, of the effect that aminoglycosides could have on the kidney. And so it'll be very important to provide plenty of fluids to go through that kidney to hopefully help it to function better. All right, so we're going to look at carbapenems. So is the next classification that we will be looking at. Alright, so carbapenems, these are broad spectrum antibiotics, so we can use these against gram-negative and gram-positive. And some of the common medications, there's not a whole lot of them, but you have doripenem, ertapenem, imipenem, and meropenem. So they are bactericidal, and they are used for the serious infections for both gram-negative and gram-positive. Typically like lower respiratory tract infections, urinary tract, bone and joint and skin infections. And they will inhibit membrane synthesis, leading to cell death. So the pharmacokinetics of these drugs, they're primarily given or rapidly absorbed if given IM, and reach peak levels at the end of the infusion if they are given IV. They're widely distributed throughout the body. With carbapenems, we're not real certain about the crossing the placenta or the breast milk. We just have not seen that in particular, or know that for sure. Excreted unchanged in the urine and have a half-life of 1 to 4 hours. So some contraindications. If your patient has a known allergy to any of the carbapenems or any of the beta lactams, seizure disorders, meningitis, pregnancy, or lactation, we would not want to give this classification of medications. Adverse effects that we see with this class of drugs, we do see pseudomembranous colitis as a possibility, C. diff, nausea and vomiting, and so that could lead to dehydration issues, electrolyte issues, as well as new serious infections and super infections because of what these medications could do to the normal flora of the body. There are some drug-drug interactions that include valproic acid and meropenem, that they do have an interaction with these. Okay. Also, in thinking about your carbapenems, we're not going to give children that have CNS infections related to seizures, would not get this classification of drugs. Older adults are going to be at higher risk for adverse effects. If you have a patient who has a renal impairment, but they're on carbapenems, we would use them cautiously, maybe reduce the dosage, or depending on the patient, could be completely contraindicated. With someone with hepatic impairment, carbapenems can cause abnormalities in their liver function tests. So you see changes in their liver enzymes. In critical illness, they do have a broad spectrum of activity, and they are typically less resistant than some of the other medications that could be used. And in home care, these are not typically given in the home setting. So some of the nursing considerations for a patient receiving a carbapenem. We're going to assess, of course, for contraindications or for cautions. So, do they have allergies to either carbapenems or to any of the beta lactams? Again, we're going to perform physical assessment, culture and sensitivity testing, baseline tests related to orientation, reflexes, vital signs, and renal function tests. We would not give carbapenems to anyone who also has a severe allergy to penicillin, which is a beta lactam. IM administration would not be recommended with severe or life-threatening infections. We can add lidocaine, can be added to an IM administration, and that would decrease the pain of the actual injection. Also, meropenem is given for treatment of febrile neutropenia. So here's our a prototype card here for your carbapenems, and this is for ertapenem. That's the prototype in your textbook that we use to treat community-acquired pneumonia, as well as GU infections, intra-abdominal infections, skin infections, and pelvic infections, given IV or IM with a half-life of around 4 hours. And you see here listed some of the adverse effects. So there's your pseudomembranous colitis, pain at the injection site. And so we did mention that you could add like lidocaine might be ordered to be added with this to make that IM injection a little more tolerable, a little less painful. All right, so we're going to move on to your penicillins. And, uh, you know, take a look at when life gives you mold, let's make penicillin. And what does penicillin do? So, you've got penicillins here with lots of different types of activity. Some that can be narrow spectrum. You've got staphylococcal, anti-staphylococcal, you got penicillinase resistance, you got broad spectrum penicillins, you have extended spectrum penicillins. And so we group these together as beta-lactam antibiotics. That's the classification that your penicillins fall into. But also considered beta-lactam can be your cephalosporins, your carbapenems, your monobactams, and your beta-lactamase inhibitors. So you have beta-lactamase inhibitors. They're going to prevent bacterial degradation of beta-lactam antibiotics and extend the range of bacteria that the drugs are going to be effective against. So, for example, you have ampicillin and sulbactam, which gets us unicin. Ampicillin plus clavulanic acid gets you augmentin, and tarcocillin plus clavulanic acid is timentin. So these combination drugs are bound with other beta-lactam antibiotics, and they act as competitive suicide inhibitors of the bacteria's beta-lactamases. They bind with the enzyme and allow the antibiotic to reach the target site, so that they're going to act more effectively together than they did separately. And then there's another one, piperacillin and tazobactam. So with your penicillins, your prototype is amoxicillin or dicloxacillin or diapan. So amoxicillin, here's your drug card for your prototype. So treatment of infections caused by susceptible strains of bacteria, post-exposure prophylaxis for anthrax, treatment of Helicobacter infections as part of a combination therapy. And so they're going to affect the cell wall, causing cell death. Amoxicillin is typically oral, half-life of 1 to 1.4 hours, excreted unchanged in the urine. And so here's our adverse effects: nausea, vomiting, diarrhea, so GI effects particularly. It can cause infection and irritation in the mouth, as well as bone marrow suppression, superinfections, rashes, fever, and lethargy. Okay, so just a little bit about our penicillins. They're derived from fungus. We do call them beta-lactam drugs, and that's because they have a beta-lactam ring that is essential for antibacterial activity. So they have to have that, so that they work correctly. And so the issue with these drugs, and when we talk about beta-lactam, these as beta-lactam drugs, is that the bacterial cell wall is rigid and it protects the environment of the cell. So anything to disrupt this wall is going to cause the death of the cell. So drugs that affect the cell wall, like penicillins, must be able to penetrate the membrane of the cell. So beta-lactamases are enzymes that disrupt the beta-lactam ring. So that's part of what penicillins have that help with their antibacterial activity. The production of beta lactamase enzymes to disrupt the beta lactam ring, which is a major mechanism by which microorganisms acquire resistance to these drugs. They are bactericidal. They can be narrow spectrum like penicillin G, or they can, or in this category, you also have drugs that are broad spectrum like aminopenicillins. They commonly destroy gram positives like strep and staph. Adverse effects commonly reported are things like gastrointestinal, like nausea, vomiting, diarrhea, abdominal pain, allergies, where typically a rash is the first sign of an allergy, like on the abdomen, the scalp, or the arms. Um, blood dyscrasias or hematological reactions like prolonged bleeding or decreased hemoglobin, and super infections like you see here in this bottom picture, thrush or yeast infections that we might see with patients. As far as nursing implications, of course, we want to do assessment. We want to know about their allergies to medications, in particular beta lactams and your penicillins. In general, some of the things that we would assess would include the site of infection. You know, we do a culture and sensitivity to make sure that we're using the most appropriate antibiotic. We would do an assessment of the skin, you know, color, lesions, respiratory system, you know, assessment, of course, of breath sounds or adventitious sounds, GI system, you know, bowel sounds, urine output, lab data. If necessary, we would do liver and renal function tests. Some of the things to keep in mind related to implementing these medications. Culture and sensitivity tests should be performed before beginning therapy. Typically, your beta lactam drugs are stored as a suspension in the refrigerator and have to be shaken before each use and using the appropriate measuring device. We would monitor for and provide hygiene measures and treatment for super infections like thrush or candida. We would monitor nutritional status and fluid intake, particularly if they develop diarrhea. Provide appropriate perianal cleansing and care if diarrhea becomes a problem, which with penicillin it usually does. Provide comfort measures to deal with ear pain, warm compresses, analgesics. Provide patient's family with teaching regarding the drug name, the dosage, how to store the medication, how to measure it, adverse effects, things that are common, also other possible adverse effects and warnings, what should they report to the physician. In patient teaching, we would want to mention several things. So this would be a medication that we prefer to take on an empty stomach. And typically we'll drink that or take that with a full glass of water. It is known to cause adverse effects, particularly things like diarrhea, and so being aware of that. I will tell you that although we do prefer taking penicillins or your beta lactams on an empty stomach, they can be taken with food, but it is going to decrease the absorption of the medications. An additional method of contraception should be used for females who are taking your beta lactams, because it will interfere with the effectiveness of oral contraceptives. Think about any kind of aseptic technique that needs to be used, like with procedures, with taking care of this patient and making sure that we're, not spreading infection and that we're using everything appropriately. And then teaching about super infections, candida, maybe the possibility of adding yogurt, and good flora to the body, maybe kind of helping to replenish that, probiotics, yogurt, things of that nature. And dietary changes, and essentially that's what we might add is more yogurt, more probiotics to the diet while someone is taking penicillins. All right, so we're going to take a look at cephalosporins. All right, so your category of cephalosporins, they are related to your penicillins. Your cephalosporins were introduced in the 60s. They are similar to your penicillins. They're bactericidal. And there are, depending on which book that you read, 4 or 5 generations of the drug. So they have kind of changed over the years. They've added more drugs, and they call them by generations. Each generation of your cephalosporins have kind of a little bit different spectrum of activity. If a patient is allergic to penicillins, there's up to about 18% or maybe a little more than that chance that they're also going to be allergic to cephalosporins. So quite often, if someone has an allergy to penicillins, we may see that cephalosporins are not ordered. I have seen cephalosporins ordered for some patients who have taken them before, but have an allergy to penicillin, but that they know that there's certain cephalosporins that they do okay with, and a physician would make that determination. But most often, the answer is allergic to a penicillin, you're also allergic to a cephalosporin. Okay, so in looking at uh, this, they are classified by the generations. And so you can kind of see, I think your textbook lists it in 4 generations. And so you can kind of see it goes from being mostly a gram positive in activity to the later generations have both. The very first generation of drugs is cefalozolin, as an example, or Ancef, and it's typically the drug of choice for surgical prophylaxis. Your second generation is used more with like gynecological surgeries or colorectal surgeries. Cefatitan or cefatan or cefoxitin would be second generation examples. Third generation are highly resistant to beta lactamase activity. And so an example of this would be ceftozoxone or Rocephin. Fourth generation is activity against both gram positive and gram negative. And so cefepime, or I think your textbook also includes ceftaroline, which treats community-acquired pneumonia and skin infections, as being considered as a fourth generation cephalosporin. All right, so let's take a look at some other details. They are similar to penicillin in structure and activity, so thus, if you're allergic to a penicillin, you're allergic to a cephalosporin. Some of the common medications, so here's some of the ones that I just mentioned to you in the previous slide. So there's your cefadroxil, so you have your Ancefs, you have your C-chlors, cefatoxim, there's your Rocephin, ceftaroline, so you have quite a bit. So if you look at all of these, though, you kind of see that they do have in common, like penicillins have the psyllin part in common. Your cephalosporins have the CEF starting the name of each of those medications. So I can kind of recognize that those are cephalosporins. All right, so looking at cephalosporins, um, the pharmacotherapeutics, um, you know, some of the things that we do know about how these drugs work is that they can be bactericidal or bacteriostatic depending on the dose. They are well absorbed from the GI tract, metabolized in the liver, excreted in the urine, and they do cross the placenta and enter into breast milk. As far as contraindications, we would avoid giving cephalosporins to someone with known allergies to cephalosporins or to penicillins. They also may be contraindicated with hepatic or renal impairment. And depending on the physician, they may view renal and hepatic impairment as either a caution or as a contraindication that they may not be willing to give. We do know that cephalosporins can become toxic to the kidneys and they can become toxic to fetuses. As far as interactions, we do know that there are interactions between cephalosporins and aminoglycosides, which increases the risk of nephrotoxicity. There are interactions with cephalosporins and oral anticoagulants, where there could be increased bleeding. We would want a patient who's taking a cephalosporin to avoid alcohol because they can have a disulfiram-like reaction where it will actually cause them to have like flushing and headache and chest pain and palpitations and blurred vision. The prototype in your textbook for your cephalosporins is cefaclor, okay, which I've included a picture of right there. And so here are some of the common adverse effects of your cephalosporins. And these do also include super infections. So nausea, vomiting, diarrhea, rashes, headache, anorexia, abdominal pain, flatulence, and super infection. So patient education, we would assess for allergies to cephalosporins or infection or to penicillins. Perform a physical assessment. Look for any skin rashes or lesions. That could be an indication of an allergy. Culture and sensitivity testing and renal function testing. So we always would want to do a culture and sensitivity report to make sure this is the drug of choice for the patient. Monitor renal function testing values before and periodically during therapy to make sure that we're given the most appropriate dose and reducing it or increasing it as needed. Ensure that the patient receives the full course that's prescribed, divided around the clock to increase its effectiveness. Monitor the infection site and presenting signs and symptoms throughout the course of therapy to see if those symptoms are starting to resolve. And, small frequent meals, frequent mouth care, because some of the adverse effects could, cause a sore mouth, infected gums, things like that. Monitor the patient for any signs of super infections and make sure that those are treated effectively. Monitor injection sites regularly, warm compresses, gentle massages if they become swollen or painful, or if they develop phlebitis, like if we're giving it IV. And you see inflammation of a vein, you don't want to continue giving medications. In that, we would have to remove that IV line and restart into another vein. Initiate safety measures like side rails, help with ambulation if they start to have CNS side effects. Make sure that the patient's knowledgeable about their dosing schedule, about side effects, and make sure that they're aware of what kind of safety precautions to take, like changing position slowly, drinking lots of fluids, maintaining their nutrition, and what to report. Things like difficulty breathing, severe headaches, severe diarrhea, dizziness, or weakness. Your cephalosporins can cause depletion of vitamin K. We can give vitamin K as a treatment to that to treat bleeding, but it's not going to restore normal platelet function or normal bacterial flora in the intestines that normally produces the vitamin K in the body. May have an effect on patients with heart failure. Do not give to patients with life-threatening allergies to penicillin. Don't mix ceftriaxone and IV solutions that contain calcium. And if we're administering orally, cephalosporins can be given with food or with milk. And again, we would avoid consuming alcoholic beverages while receiving cephalosporins and for at least 72 hours after completing the course because of those serious disulfiram-like reactions like chest pain, palpitations, syncope, blurred vision, or flushing. So we do need to be aware of those drug-drug interactions. Don't give with a severe allergy. IM administration would not be recommended if it's a severe or life-threatening infection. Lidocaine can be added to IM to decrease pain. And meropenem is given for treatment of fibromyalgia. Okay, so cefaclor is our cephalosporin prototype. And you can see here its half-life is fairly quickly, and when they are at risk for superinfections, bone marrow depression, and pseudomembranous colitis. All right, so we're going to take a look at fluoroquinolones. All right, so with your fluoroquinolones, our classification, it's a fairly new class with broad spectrum activity. Here are some of the common medications. So ciprofloxacin, levofloxacin, those are a couple that we use quite, probably two of the ones that we use most widely, so or known by their brand names Cipro and Levaquin. So when we're looking at fluoroquinolones, they are bactericidal. Their indications are for gram-negative bacteria, particularly urinary tract, respiratory tract, and skin infections. Interferes with the DNA replication process and prevents cell reproduction. They are absorbed in the GI tract, metabolized in the liver, excreted in the urine, feces, cross the placenta, and can also enter into breast milk. So some additional information. We do consider those to be a very broad spectrum antibiotic. They will kill rather than inhibit. Ciprofloxacin is most active against aerobic gram-negative organisms. These are not indicated for children under 18 or for pregnant women. Your adverse effects do include GI upset, headache, photosensitivity, dizziness, and rashes. We can give on an empty stomach, but be aware they do have a black box warning that Your fluoroquinolones can cause an increased risk for tinnitus, or tendinitis rather, and tendon rupture. Um, and cartilage erosion could be apparent in children. Um, Also, if it does cause GI upset, like Cipro, for example, we could give it with food instead of on an empty stomach if that would help with the GI upset. Also, with fluoroquinolones, they are the first line of treatment for anthrax. So, with bioterrorism, we would be very familiar with fluoroquinolones as a treatment. Black box, here's your black box warning again: tendinitis and tendon rupture. And there's lots of interactions between your fluoroquinolones with other drugs, other foods, and other herbs mentioned in your textbook. If we see a skin rash or other hypersensitivity reaction, we should discontinue the medication and make sure that we're monitoring kidney function through like BUN, serum creatinine, and creatinine clearance information. For your fluoroquinolones, we would recommend that patients drink 2 to 3 quarts of fluid daily if that's possible for that patient, to prevent crystal urea or crystals forming in the urine. So we want to keep them very well hydrated and fluids going through their kidneys to prevent crystal urea. Some contraindications to your fluoroquinolones would be known allergies, pregnancy, lactating women, and renal dysfunction, which I believe I misspelled there. Adverse effects would include some of the more common ones are things like headache, dizziness, insomnia, and depression. Drug-drug interactions, there are known interactions between your fluoroquinolones and antacids, quinidine, and theophylline, and these are mentioned specifically in your CARSH textbook, so you should take a look at what those will do. Nursing considerations for patients receiving fluoroquinolones. We'll look at, we've mentioned, essentially these same things with other classifications. So we want to make a thorough assessment of our patient so we have a baseline. We don't want to give medications if there are known allergies. We want the culture and sensitivity tests in place. We want to make sure that there hasn't been a rash, which could be a sign of hypersensitivity, and we want to make sure that the kidneys are functioning well when we're given any of these medications. Your prototype is Cipro, given for a variety of reasons, but anthrax is included, but also respiratory, skin, urinary tract, eye, ear, bone, and joint infections. Um, and so you have oral and you have IV administration that's possible here, and a lot of GI possible adverse effects are the things that we see more often with these medications. Your sulfonamides is another category, and these are drugs that will inhibit folic acid synthesis. And your common medications are sulfadiazine, sulfasalazine, uh, cotrimoxazole or Septra. Uh, they are bacteriostatic anti-infectives, and they block particular acid that will prevent the synthesis of folic acid in that particular bacteria. And typically, it will treat infections both gram-negative and gram-positive. They're well absorbed from the GI tract, metabolized in the liver, excreted in the urine, and they are considered to be teratogenic, meaning they are definitely dangerous medications. We don't give them during pregnancy in particular. So the contraindications would be allergies, use of thiazide diuretics, and pregnancy. They are known to cause adverse effects of GI symptoms, also renal effects related to the filtration of the drug through the kidneys. There are drug-drug interactions with these medications listed here. Some of those are anti-diabetic medications. And so do look at your CARSH book for some of those drug-drug interactions, that we need to be aware of what they could do. We wouldn't want to give those medications together, or at least be aware. Nursing considerations. Again, we want to assess for allergies to sulfonamides, sulfonylureas, or thiazide diuretics. We want to know about their physical status, their skin, their mucous membranes, look for any signs of allergies. We want to make sure that we have already collected specimens for culture and sensitivity, that we're aware of like their respiratory status, their orientation, their affect, and their reflexes. We need baselines to go on. But in addition, we would want to assess their abdomen, their renal function tests, and a complete blood count so we're aware of what is physically going on with our patient. Your prototype here is clotramoxazole or Septra, used with urinary tract infections or acute otitis media in children. As a couple of examples there. Half-life is 8 to 10 hours, given orally. And you can kind of see down here under adverse effects lots of different ones, including bone marrow suppression, urticaria or rash, but also GI effects like nausea, vomiting, and diarrhea that we often see, but also photophobia, fever, and chills. We'll take a look at tetracyclines as well. Tetracyclines are kind of an interesting classification of medications. They are semi-synthetic based on structure of common soil mold. So that's kind of where we synthesize those from. And they include tetracycline, demeclocycline, doxycycline, minocycline are some that you would see in this category. They are bacteriostatic. They will inhibit cell replication by inhibiting protein synthesis. They are used to treat various types of infections. Can be used to treat acne as well, or in situations where penicillin is contraindicated. They are absorbed fairly well in the GI tract, concentrated in the liver, excreted through the urine, and they do cross the placenta and cross into breast milk. They are contraindicated with known allergies to tetracyclines, to tartrazine. They're contraindicated in pregnancy, lactation, and kidney and hepatic dysfunction. Also contraindicated if they're also taking penicillin G, oral contraceptives, methylfluorine, or digoxin. Adverse effects are mostly GI effects, but there are some possible damage that we think about to bones and teeth. It can discolor the teeth, and it can affect the bones. Drug-drug interactions, of course, would be to penicillin G, oral contraceptives, and digoxin. So we do not want to give tetracyclines with those three types of medications. Nursing considerations, of course, we're going to assess for allergies. We want baseline information for our patient, including their physical status, looking at the skin for possible signs and symptoms of allergies. We want specimens for culture and sensitivity before we start medications, respiratory status, kidney and liver function status. Your prototype is tetracycline, and you do not want to give this to children because they're forming their teeth. You really don't want to give it to pregnant women either, because it will cause discoloration or inadequate calcification of primary teeth in a fetus of a pregnant woman, or secondary teeth if we use it in children. So it is contraindicated in those populations. It can also cause superinfections and bone marrow suppression as well. All right, so here's a question for you, a true false question. Sulfonamides should not be given with thiazide diuretics because of a cross sensitivity of the drug. So let's see if that's true or false. And that would be true. There is a cross sensitivity with thiazide diuretics and sulfonylureas. So we're going to look just a few more slides at some of the other antibiotics that are mentioned in this chapter. So you have your ketolids, lincosamides, lipoglycopeptides, macrolides, oxazolinones, and monobactams. Those are all medications that don't really fit into any of those other categories of those larger classes of antibiotics. So this would be like telithromycin, clindamycin, azithromycin, clarithromycin, linezolid, or aztreonam, or Azactum. And so when we're looking at these other antibiotics, most of these we can kind of group them together and say, okay, yeah, they're bactericidal and bacterial static. They're used to treat severe infections. They are rapidly absorbed, metabolized by the liver, excreted through either the urine or the feces. They do all cross the placenta, but they do not cross into breast milk. So if there's known allergies to any of those medications, of course, we would not give them. Contraindications and cautions with hepatic or renal impairment, myasthenia gravis, pregnant and lactating patients, phenylketonuria, and MAO inhibitors. Adverse effects are mostly CNS and GI effects, but it can also cause liver enzyme elevation and super infections. There are drug interactions, and so we do know that if they're taking medications like the oxazolinones and MAO inhibitors, that there also would be a problem with foods that contain tyramine, which would be like your aged cheeses like blue cheese, wine, beer, sauerkraut, anything that's fermented has like tyramine in it. So take a look at your textbook for those lists of medications that have, or foods that have tyramine in it that would interact with some of these medications here. So nursing care would include, of course, assessment. We wouldn't want to give if there are known allergies. We're doing cultural sensitivity. We want to look at liver function, kidney function, and where their baseline physical status brings them as well. We would also assess temperature to detect infection. Of course, that doesn't really work with your older adult as well. Liver and kidney function test values, baseline EKGs, kind of to see how they are functioning as well might be something. Your prototype for grouping these other antibiotics together is telithromycin, which is used to treat community acquired pneumonia orally. And it has a half-life of 10 hours. It's excreted in the feces and the urine, and it can cause some of those more serious effects like superinfections and pseudomembranous colitis. You have clindamycin. Since all of these kind of have like their own kind of drugs, I kind of pulled out a few of these. And so clindamycin can be given orally, IM, IV, or it can be a topical. And so, like the EKG, why we would want a baseline on that, this is the medication that would be a problem: cardiac arrest with rapid IV infusion. So, kind of causing some cardiac issues. Erythromycin can be oral or IV. And it can also cause, there's some potential for hearing loss. There's also some potential for liver toxicity with erythromycin. And then atrazanam, which can be IM or IV, used for lower respiratory tract, skin infections, urinary tract infections, gram-negative infections, and these are your, I believe, your macrolide. This is your macrolide medications. Let me look back here and make sure I'm telling you correctly. Let's see, I'm looking at the wrong page, so give me just a second here. Yes, definitely looking at the wrong thing. Your monobactums. This is your monobactum. I'm sorry. Your monobactum. So, lower respiratory tract, skin infections, urinary tract, gynecological infections, given IM or IV. And you can see, primary thing is most serious things, of course, is anaphylaxis, but also superinfections and local discomfort at injection sites. So let's look at a question, kind of ending this presentation. So macrolide antibiotics have known food-drug interactions. What would you teach your patient taking a macrolide antibiotic? Take with meals. Take daily just before getting or going to bed. Take daily upon arising in the morning, or take 1 hour before, or at least 2 or 3 hours after a meal. So give that some thought. And the answer is take 1 hour before, or at least 2 or 3 hours after meals. So, with a lot of your medications, and in particular oral macrolides, food in the stomach decreases absorption. So, we would administer the antibiotic on an empty stomach with a full glass of water, like 8-ounce glass of water, either 1 hour before or 2 or 3 hours after a meal, so that it will be absorbed more effectively.